than what's available for cancer already. And then, even though the intellectual property rights help you, you still have the reality that in the RASopathies, we're talking about rare diseases. And so, drug companies want something that'll sell billions of dollars worth. That's a little hard to accomplish if the drug turns out to be useful only for the RASopathies. So that's the trade-off, and you can understand why we turned first and foremost to repurposing, because it gave us a way to get at this problem relatively more rapidly. I want to make the point that the way we think of drugs for the RAS pathway in the RASopathies is a little different than the way we think of it for cancer. And Gregor Andelfinger developed this graphic or cartoon to show you the idea. I will say it was something I put out to him, but let's just pretend on the left, shown in the lighter gray, up or down, is a person, and this is the normal level of RAS signaling in the body everywhere, because we know the RAS pathway is everywhere. Here on the very right, we're pretending we're talking about somebody with cancer that has a change in the cancer that causes the gain of function, so too much in the RAS pathway. So we're showing that here with a sort of red hotspot, so this would obviously be a brain tumor. So the idea with the medicines is to take something at the highest dose you can tolerate, to turn off the pathway as best you can, to down regulate the pathway, because we know that cancer cells, once they're turned on this way, if you turn it off, they hate that and they just shrivel up and die, which obviously in cancer care is exactly what you want. The problem, however, is you're using high dose medicine to turn off the RAS pathway. So although it'll tone down what's going on in the tumor to help you fight the tumor, it also turns it off everywhere else in the body. And that may not be so well tolerated, certainly not for a long time, because certain parts of our body really depend on the RAS pathway. So, for instance, our bone marrows, which make blood cells, absolutely need the RAS pathway in order to keep that going, to keep the cells multiplying and making new blood cells, which we need constantly. So that's how cancer care works. So imagine now a child with RASopathy. You can see immediately, as we've depicted, that it's different than cancer. First of all, there's gain of function in the RAS pathway everywhere. Here in cancer, it was only in the tumor because this was a gene change that was acquired sometime after birth, in adulthood typically. And here we're talking about a child with, let's say, CFC, who was born with this and has the change in the gene in every cell in their body. The second point is we don't want to turn off the pathway like we do here to kill the cancer. Here, we just want to try and tone things down and get things back to normal. So we've depicted that by showing using a lower dose of the drug to get at the idea that maybe we can just tone it down instead of turn it off by using the lower dose. And this is also important because for some indications, you might need to use the medicine for life. So to use a CFC relevant example, if we thought we could use MEK inhibitors for epilepsy to prevent seizures, I we don't have any reason to think that that problem would go away and you could stop the medicine after a certain period of time. We would imagine the seizures would come right back as soon as the medicine went away. So therefore, you're going to have to use it indefinitely. So you really can't afford to just turn off the pathway everywhere. So sorry to get a little preachy there, but that's how we've been thinking about treatment. And it's important to understand it's different for kids with RASopathy compared to individuals where we're fighting cancer. Okay, so now we're going to get into, the work on the MEK inhibitors and how hopefully, some hope is coming up over the horizon here. So, as I told you, we first sought to use drugs that already existed. And the class that we turned to were MEK inhibitors. And MEK inhibitors, unsurprisingly, are drugs that stop the two proteins we have that are called MEK1 and MEK2. You may know that those are two of the genes, they are encoded by two of the genes that, when changed with gain of function, cause CFC. I should say that the other CFC gene is BRAF, which is sitting right up here, right above that. It's the protein that activates MEK 1 and 2. So this is the point where you're blocking the pathway here. We've also put in another drug, the rapamycin analogs. That blocks a totally different place, and this is really just relevant for children with NSML. It's not really relevant for CFC or any of the other RASopathies. Okay. So, what MEK inhibitors were out there? At this point, as we meet tonight, there are four MEK inhibitors that have been approved by the FDA. They're all quite similar in how they work. They have slightly different chemistry, but fundamentally, they are a class of medication, kind of interchangeable as far as we know. So the very first MEK inhibitor that was developed was called trametinib. That's what we're going to talk about mostly tonight. It was approved more than a decade ago, and it was approved first for the use in melanoma for individuals who have melanoma due to certain BRAF mutations that we don't see in CFC. These are very strong mutations. And this drug was approved to be used in accompaniment with a drug that specifically blocks the altered form of BRAF in this cancer. And it was subsequently approved for other cancers as well. There were then two other MEK inhibitors, pretty similar, also approved for cancers, mostly for melanoma, that have been approved over the next few years. And then there are two pediatric indications for which we have MEK inhibitor approval. So the first was selumetinib, which was 2020. It was a trial for one particular aspect of neurofibromatosis. And then trametinib was 2 years ago was approved for use in children for brain tumors. Not just any brain tumors, but again, brain tumors with BRAF changes. And one thing that's a positive for our community about the approval of trametinib for this pediatric indication is that well, there are two nice benefits from this. First, the drug company is now making a liquid form of the medicine. When we first started with trametinib, we only had access to the pill form, which obviously is more difficult when we're dealing with infants. And the second thing is that they did some of the development work to actually try trametinib down to ages as low as 6 months. Now, we're starting a little bit earlier with the severe hypertrophic cardiomyopathy, but at least there's been reasonable testing of trametinib in children. Okay. What do we know primarily from adults, some extent from children, who have cancer who've been treated with MEK inhibitors? And the side effects seem to be common across all the various MEK inhibitors. They're what we call class effects. They're not specific to one drug over the other. So as you can see, there's a pretty long list here of things that can go wrong, starting with the commonest, which are problems with skin, GI problems, with the GI tract not working properly, or what's called stomatitis. Stoma refers to the mouth, so you get mouth sores basically. And then a wide variety of other things, some of them a little scary, like decreased function of the heart muscle, problems with the retina, and problems with the lung tissue itself. Fortunately, even the most severe problems seem to go away when the medicine is stopped, when those problems pop up. Now, it should be said that we didn't know when we started with the first babies and giving them trametinib to what extent we would see the same problems in them as we have seen in people with cancer. And I explained to you that the biology is a little different, that the kids with RASopathy have a change in all the cells. They have increase in the RAS pathway everywhere. So you could imagine that they might have fewer side effects when exposed to a MEK inhibitor than other persons. And also, I explained that we would be using somewhat lower doses, and that might be helpful in reducing side effects as well. Whether that's actually true, I don't know. I'll present what we know, but it's still a little bit of an unknown. One last thing to say before we get into use of MEK inhibitors in the RASopathies is that when you're getting ready to develop a drug, you typically want to test it in some preclinical manner, meaning before you give it to a human, in other ways. And the two ways we do this are shown in this cartoon. On the left side are so-called in vitro models that basically refers to exposing cells to the drug and then seeing how they respond to the drug. And then we use animal models. That's what's referred to as in vivo, so in life models. And for genetic disorders, by far and away, the commonest model to use is a mouse model. And that's simply because it is relatively straightforward to make a mouse model into which you've introduced the gene change that causes CFC or Noonan or what have you. It's relatively harder and certainly far more expensive to start creating, for instance, a pig model with Noonan syndrome or CFC, etc. So the first I'm going to show you a little bit of preclinical work. Not, there's lots more out there, but I'm going to show you a little bit in the rhasopathies just to give a feel for it. So here is results of a model, a mouse model of Noonan syndrome, and it was specifically for the gene RAF1. And you may know that in Noonan syndrome, children born with RAF1 change as the reason for their Noonan syndrome are highly, highly likely to develop hypertrophic cardiomyopathy. And I think people on this call will likely know that that refers to a problem where the heart is too thick, too big, and this is what can lead to the heart failure and other illnesses in children who have it. So here they've made the mouse. So here's the heart from a normal mouse. It's small, of course, mice are tiny. And here, and obviously quite bigger, is an same age, probably a littermate mouse where it has the change that causes Noonan syndrome. And then when they measure the thickness, you can see the thickness of the heart is increased. And then if you care, this is actually looking at the heart muscle cells that, relatively speaking, these are smaller than these. These are too big. And so, bottom line is, we know that this mouse has successfully showing the same problem in the heart. It showed some other symptoms of Noonan syndrome as well. So the group that did this was Ben Neal's group. He was up in Toronto at the time. He's now at NYU. They studied this mouse. Not surprisingly, they showed that there was increase in signaling through the pathway. We would expect that. But then they went ahead and tried drug treatment. So they used a different MEK inhibitor. It's one that's not FDA approved for anything at this point, called mirdametinib. And the it was successful, but they did this like if I were designing it, I think I would have done this a little differently, honestly. What they did is they treated the mice for 6 weeks, starting at 4 weeks of age. And they already had shown that the mice at 4 weeks of age did not have HCM. So they were basically trying to prevent HCM, not take mice that have HCM and make it go away. And the reason that matters is if you want to know what to do with kids, I think it would be unlikely we would be treating babies before they have HCM because the drug's just too powerful and all that. So it's not the perfect experiment, but at least it gave us some idea that a MEK inhibitor might work for HCM in Noonan syndrome. Well, how about CFC? The data is not quite as good, and that's because the mouse models of CFC seem to be much more severely affected than the mouse models of Noonan syndrome. And in fact, the BRAF model that was produced does not survive the embryonic period. Those mice die in utero. And so shown here on the right is a developing mouse embryo. And these spots that are being shown with the arrowheads, this is where bleeding is going on. So that's a sign of bad health. And also you can kind of see that there's extra fluid around the mouse. And that's also a bad sign in developing mice. And these mouse embryos will go on to die. So they don't survive. But the group did try drug treatment. They tried 7 different drugs, not 7 different MEK inhibitors. They only tried one MEK inhibitor, the mirdametinib, but they tried 6 other drugs affecting other signaling pathways. The only one that worked was the MEK inhibitor, and it worked partially. It didn't completely rescue this mouse, but still somewhat encouraging. So that's examples of the preclinical data that led us to think that maybe MEK inhibitors might be worth the try in children struggling with rhasopathy. So the next step came in 2017. oddly enough, within a 2 week period, I had pediatric cardiologists contact me, one from Germany, and one from Montreal, and that was Gregor Andelfinger. They both were caring for babies with Noonan syndrome who had very severe hypertrophic cardiomyopathy. They were both in intensive care units. As it turned out, they had the cause of their Noonan were both RIT1. That doesn't really matter. They had already maximized out how much of the standard drug therapy, which is called the beta blocker, they gave them. And so they were like, "What do you have any ideas? What could we try?" And I basically said, "Well, if we're going to throw a Hail Mary here, I think we should try a MEK inhibitor, and I think we should go with trametinib." The other drugs were not yet out. This was the FDA one, the FDA approved one. And so Gregor, at his institution in Montreal, they have wonderful uh, scientists who figure out dosing of medicines for kids. So they worked out a dosing regimen in trametinib, and it's still the regimen we're using today in terms of how much to use. And then both doctors got permission locally to be able to use trametinib on what we call a compassionate usage basis, because obviously we had no data it would work in the kids. We were just trying to save their lives. And happily, both of those babies survived and improved. They were kept on medicine for quite a while. They were weaned after something under a year. In both cases, it seemed like the HCM came back, and both were put back on medicine. And then a few years later, at about age 3 or so, both of them were able to come off medicine, and the HCM has not come back, and they've done well. So that was very encouraging, but just because something works in two people does not prove that it really works. You could argue maybe this could have happened by chance, even, although I have to say I had never seen that happen. It's not proof. It's exciting initial data. That's what it was, and that's what we recognized it as. The next thing that happened, which was, and that we published our paper in 2019 describing this experience, and that quickly led to the use of trametinib in kids with HCM. But people started using it for somewhat other serious conditions in the RASopathies. So the next, I think, was from Yoav Dori's group at the Children's Hospital of Philadelphia, also known as CHOP. And they had a 16-year-old with Noonan syndrome due to a SOS1 change. SOS1 changes are associated with problems with the lymphatic system, and this teenager was having severe problems with leakage from her gut and the lungs. Um, and they had shown by imaging that the lymphatics were very abnormal. They had done the medical and interventional things that they knew to do. Um, and they just couldn't get her better, and she was just failing, and if they didn't do something she probably would have died. And so they decided to go ahead and use trametinib, and saw really a very rapid, within 2 months her symptoms resolved. And I have not spoken to Dr. Dory about this in a while, but last I had, this patient remained on medicine and was doing very well. So here, just to give you an idea, I'll show a couple pictures. So here, the white stuff is imaging of the lymphatic system, and this stuff over here is very abnormal. There isn't something similar on this side. It wouldn't be present in most people. So that's a very abnormal lymphatic chamber, and you can see vessel rather. You can see that after they put her on trametinib for a bit, this is really resolved. So that's pretty incredible. And then here is a picture of her gut, and what you're seeing, these like white cobblestone-like appearance, this is dilatation of the lymphatic channels in the lining of the gut. It's very abnormal. And you can see that after they treat her, that this largely resolves. So again, vast improvement due to MEK inhibition. So since then, so that was published 2020, and in the roughly 5 years since then, there have been a number of publications. I may have missed one or two here. So if you have one that your child is described in or something you know about, I'm sorry if I missed it. But here's the use of trametinib in the RASopathies. Nearly all of it has been in Noonan syndrome. It has generally worked, but not always. There's been at least one case where the baby really didn't get better and went on to die. It's been used for heart rhythm problems. That's what this is here. There is, as you move to 2023, there was a child with Costello syndrome, who was treated successfully for hypertrophic cardiomyopathy. And then that year, there were two children with CFC, both with epilepsy that was drug resistant, who were treated. And I'm going to go over those cases because I figured those would be of interest for this group. And so it goes. So let me tell you about those two children with CFC who were treated for epilepsy. The first was a 7-year-old girl. She had CFC due to a BRAF change. She had drug-resistant epilepsy with multiple seizures a day. They put her on trametinib, and she was seizure-free by 6 months. And and then the second is a 5-year-old boy with CFC. This was due to a KRAS change, again, drug resistant epilepsy, and was age 26 months when they started it. So this is from the first child, and these are EEG waves. And I know I don't know how to read EEGs. I'm going to guess none of you do either. But I can tell you that these very sharp, spiky things like here, that's seizure activity. The other waves are more normal activity, and you can see the spiky stuff is gone after the trametinib. So the seizures this child was having have resolved. With the 5-year-old, unfortunately, the experience was less good. When they started 26 months, there was a reduction in seizure frequency, so that was encouraging. But the seizures came back about 6 months after being on the drug. And then, after almost 2 years being on the drug, one of the GI side effects occurred from trametinib, which was colitis, meaning inflammation of the intestines. And that forced them to have to stop the medicine. And when they stopped it, there was sort of a rebound and the seizures came right back. So, depending how you read this, encouraging that there was the initial response, but a little bit frustrating that they came back. And then, of course, that they had to stop the medicine, period. Well, this is all pretty encouraging, and I can tell you that after we treated those first two babies in 2017, Gregor Andelfinger and I immediately thought, well, we've got to find a way to get this developed for the rhasopathies. How are we going to do that? Well, the drug trametinib was and is owned by the drug company called Novartis, and we started a discussion with them. And sadly, ultimately, they decided as a company not to develop, not to invest in the rhasopathies. They did say they'd be willing to give us free drug to do a trial, but they weren't, and that was nice, but they were not willing to fund the trial itself, and that requires millions to pull off. So we were stuck. And then, because there are drug companies developing new MEK inhibitors, Gregor and I were constantly fielding calls, and we went on lots of Zoom calls with groups thinking about doing it, but finally we got one to bite, a company called Day One Pharmaceuticals. They had a MEK inhibitor called pimasertib. And then Gregor and I, along with two colleagues from Germany, Cordula Wolf and Martin Zenker, spent the better part of the next 2 years having weekly calls with Day One. They were all in. They were prepared to develop their MEK inhibitor, pimasertib, for more than one thing in the rhasopathies. We had developed the trial for starting with rhasopathy, HCM, and we had met with the FDA a couple of times. And then in the summer of 23, not long after we had the scientific meeting that year, one day we all got a call to say, sorry, we decided to pull out. We're busy with a different drug. We're not going to be able to do this. And that was the end of that. So we were high and dry. And then actually things got a little bit worse because Novartis had been providing free trametinib through an access program. But when their drug became FDA approved for a children's indication, they ended the program. I'm still not clear on whether they had to or they wanted to, but they did. And then I'll tell you where we're skating to, but the paper that was published about a month or two ago, which is the retrospective review, was a step on the part of the four of us, Cordula, Gregor, Martin, and myself, to try and move the ball down the field. So this is a little bit frustrating of spending now like 8 years to try and get a drug company to develop a MEK inhibitor for rhasopathy. And we still don't have really a drug company willing to do it, but we do have Novartis willing to pay for the drug still. So that we'll take that. So what are our questions at this point? Like, I think we have a lot of very positive sign, but we haven't proved that it's working in the way that one typically would with a clinical trial. And I'll describe to you at the end the clinical trial we're proposing to do. We still don't really know what ages it works for. We don't know whether it works for all the genes except for NSML or some of the genes. Does it work better in some than we don't know any of that. And what are the best indications? We certainly have an indication it works for HCM. We have some indication for epilepsy and CFC. We have some indication for heart rhythm problems, but we don't know that much. There's also a little bit of evidence it works for heart valve problems. Um, and then, how about the side effect profile? I gave you the idea that it might be milder in the RASopathies, but that has not been worked out particularly well. So that led to a study that we just published this year that the four of us worked pretty hard on for a long time. And what I'm showing you here, I'm going to explain it because I know it looks like gobbledygook, is what's called a survival analysis. So first, I will tell you that what we did is we managed to come up with 31 patients with RASopathy and severe HCM who had been treated in the usual way. They did not get MEK inhibitors. So this is what we refer to as standard of care. And then we had 30 patients that were treated with trametinib. All of them were treated with trametinib. And then they were followed out as long as 36 months. That we ended it at 36 months. So don't worry about this point out here. So depending, some of them we hadn't been following that long, which is why the numbers are so much smaller here than here. So then what's being shown on the y-axis, the other line, is what percentage of them avoided having one of the negative outcomes that we looked at. So we looked at three outcomes. One, did the child have a heart transplant? Yes, no. Two, did the child need open heart surgery to remove extra heart muscle from the left side of the heart? And three, did the child survive or not? So we started at 100% at the beginning of the study. All the kids are alive. Nobody's had heart transplant and nobody's had the heart surgery. And you can see this is the curve here for the children who had standard of care. So that by the time you get out to 3 years, it looks like, I don't know, 15% or so have avoided one of those adverse outcomes. So that is to say 85% of them died or had heart transplant and so on, or heart surgery. By comparison, you can see of the kids whom we treated with MEK inhibitor, it's a world of difference, right? Something like 85% of them avoided any of that. So that's very impressive. I think you would understand that you don't need a statistician to see that this is the better place to be over that. But in fact, it is statistically significant, highly so. So that was very encouraging. This included babies, but it included some older children, including some older children who had had previous heart surgery, who we were trying to prevent repeat surgery on. We knew that for the clinical trial, we would wind up using the babies with the most severe form. So then we looked at those, and the numbers are smaller. We only had 10 babies with standard of care and 13 babies on trametinib. But even so, even though it's smaller numbers and therefore less power for the study, you can see that the curve of the standard care, here it's blue, is a worse outcome than the outcomes for the kids who got the MEK inhibitor. And so that was very encouraging and is the basis for the clinical trial. Now, in this trial, just for interest for this group, there were only two children who had HCM and CFC. They both had BRAF changes. One was a 10-week-old who responded well. The other was an 8-week-old who also responded well. So I don't make a lot out of just two cases, but for whatever it's worth, that's encouraging. Now, how about the side effects? I told you that these drugs have a lot of side effects. So first, our severity of side effect, from none to so severe enough that the doctors felt the need to stop the medicine or at least reduce the dosing. So you can see that this is a drug that does have side effects even in kids with RASopathy. So over 50% of the kids either had symptoms or needed to have the drug stopped or reduced because of the severity of the symptoms. And these numbers do not add up to 100%. If you do math in your head quickly, you'll realize that. And that's because there are a series of onesies that I did not include, 6 other things that were observed each in one child. So were the side effects scary in terms of what happened? And the answer turns out to be no, that of the kids that had side effect, oh, I misspoke. This does add to 100%. It's this one that does not. So here you can see that 50% of the time it was either a skin rash or a problem with the lining of the mouth, the mucous membranes of the mouth. So I referred to that previously as stomatitis. We saw a little bit of GI symptoms, a little bit of kids who have swelling. Hard to know if that's from the drug or from the being sick with heart failure. But we did not see any of them, I'd say, scarier side effects like reduced heart function or eye problems. Now, it's only 30 kids, so I cannot say that if we had 100 kids or 1,000 kids with rhasopathy who are treated, we wouldn't start to see some of those things. We might well, but at least we could say it's not happening frequently in the kids using the doses that we've been using of trametinib. So that was encouraging. So what is the path forward? And I'm coming to the end here. We'll have time for questions, but because we've been unable to um, get a drug company, the idea we came up with was to get NIH to fund a clinical trial. And the idea here is we would um, treat kids with severe HCM with trametinib and see if we got the same kind of outcome. Because things look so promising, we do not believe we could safely have an arm of the trial because you always compare the kids who get treated to something else. And in most clinical trials, that's what they call placebo, a sugar pill. We don't think that would be acceptable to parents or physicians. Just doesn't seem right. So what we're planning to do is use information we've gathered from children who got standard of care in the past and compare that. And that is acceptable when doing clinical trials. So then if that is successful, we hope to build on that and go on to other indications and then possibly work on developing additional drugs because after all, we already know trametinib is not going to be the answer for every single severe case of HCM and probably won't be the answer for other problems like epilepsy in all cases either. So here is the outline of what we're hoping to do. And shown on the right is the group of kids. We only need, because things are so dramatic, we only need about 25 babies to treat. And the idea is we would treat them for a year and then stop medicine, and then ultimately compare that to kids at a year who were treated in the standard way. And we would use exactly the same outcomes that I talked about before. And then in addition, this would be an opportunity to say, well, how often does it come back? What we refer to as relapse. And of course, if it were to relapse, we would restart the drug and treat for another year and get a sense of how effective that is as well. And if we get the opportunity to do this, if we can get funding from NIH to do this, then we would have essentially all of the rhasopathies would be eligible for if there was a baby with severe disease. So that could be CFC with the exclusion of NSML, of course, because that works a different way. So that concludes what I had to say, and I will stop sharing and be delighted to answer questions from anybody that has them.
So we have quite a few questions in the chat. Thank you so much. This was really, really great and informative. And we'll start with our
So I
first
can
question.
say that now that I'm done projecting, I can look at the chat too. So would that be
Oh,
easier if I
good.
just, yeah, okay.
Absolutely. Absolutely.
Is there any information on if the kids treated with trametinib as a baby for HCM or lymphatic did or did not develop any seizure disorder? So for the two in the trial with CFC, I don't know that. We didn't have long follow-up. So I just don't know the answer to that. I don't. We did not collect that information. There's other things we didn't collect as well that I'd love to know. That's a good question, though. Be interesting to know. Are the MEK inhibitors approved or is it just for compassionate usage for now? So when the FDA approves medicines, it typically approves them for a specific indication. So it's been approved, trametinib is specifically approved approved for cancers like melanoma, and then it got approved, as I said, specifically for children with brain tumors. What typically happens, though, is that doctors use the drugs for other things, usually things that are similar. So, for instance, they would use it for other kinds of cancer, maybe where that cancer has never been tested, but it's close enough, similar kinds of gene changes, it makes sense. The problem in the RASopathies has been that convincing insurance companies that this medicine, which is extremely expensive, is standard of care has not been so easy. And it's been the case that sometimes they say yes, sometimes they say no, and we have to fight like heck to get the payers to pay. We, the hope by doing the clinical trial is that if we have a published clinical trial, it will hopefully make it nearly impossible for the payers to say, no, we're not going to cover it because we will have proven that it works for that indication. We'll also give ourselves the chance to learn from the experience and feel braver and go on um, to do clinical trials. So to give you an example, let's say in trying trametinib in a larger group, we feel more comfortable with the side effects. Would we ever give it to children with milder but significant side effects of RASopathy? So let's take epilepsy. So far, the only kids who have gotten it in CFC are kids who had epilepsy that just wasn't responding to drugs, period. You're sort of out of options. That makes sense. But what if we could give this and the kid stopped having seizures and the kid could come off seizure medicines? That might be a great thing, but I think we want to know more about the side effects before we jump in because after all, we do have the seizure medicines and they are working imperfectly, but they are working. So that's how we're thinking about that. The next is in some of the more severe kids that have hypertension or interstitial lung disease to start with, how do you know if increasing symptoms are due to a side effect? So we have not had any children with interstitial lung disease, and hypertension is not really a side effect in the RASopathies, and those side effects are observed basically in adult patients. But it is the case
I see.
that it is difficult sometimes to tease things out in terms of figuring out what is from drug and what is not from drug. That's true on the upside too. So I'll give you an example. People frequently ask me, well, when you gave the kids um, trametinib for their HCM, did they grow better? And the answer turns out to be yes, they appear to grow better, but we don't know if that's because their heart is better and they're out of heart failure because children in heart failure tend to grow very poorly, or is it because of the fact that the medicine actually helps growth per se? We don't know that, and it would be a long time coming, I think, till we get around to treating kids just for growth who aren't otherwise sick. So, but maybe we'll get there. Pilar asks, what is your threshold for MEK inhibitor initiation, given that most of the kids who have received it were critically ill or with severe symptoms, i.e., are you at a point of treating patients with moderate HCM? That's a really hard question. Um, First of all, I'll just say that I think the insurance companies have a big role here. Like, they're typically not going to allow me to start it in moderate HCM. But let's say I could get there. I would say, as an example, there was one child with Noonan syndrome where I really wanted to use trametinib for a child for that child's pulmonary valve disease. There was pulmonary valve stenosis, blockage of the pulmonary valve. And the reason was that the child had very severe Noonan, had been born prematurely, and had bad lung disease from having been born prematurely. And I thought, well, I really would rather not send this baby to the operating room and expose him to all that risk. If I could use trametinib instead, wouldn't that be wonderful? But in that instance, I never got my chance because I couldn't I couldn't convince the payers to pay for it. I'm still, the I would say, Pilar, to answer more directly, different physicians are at different places in terms of how willing they are to use trametinib in the various kids. I will say I don't wait till a kid's in terrible heart failure to do it. If I see that it's on the more severe side, and particularly if it seems to be getting worse, I'm fine with that. But if you have a kid, especially an older kid where it's moderate and stable, I think it's a tough call. And I don't know the right answer. I would never criticize another physician who chose to do so. Neither would I criticize a physician who chose not to do so. I think that's a real gray area at the moment. And it's those gray areas I hope we get the chance to do some testing on later after we've proven the medicine works in the most severely ill kids. But we haven't been able to get to first base on that yet. And I hope that changes in the coming years. I really do. So, and then I see another question from Dana. Let me read it. It was recommended that our child have yearly echoes. It wasn't until age 35 the MRI with contrast was done. This showed scarring in ventricles that interfere with electrical pathways. This could cause sudden cardiac death. Heart rates were over 100 and were untreated for 25 years. After the MRI, a beta blocker was prescribed that kept the rate at 70 beats per minute. If we know that about this early, could it prevent the scarring in ventricles if MEK was used to treat when young? Um, well, there are a few things to say about this. Number one, in hypertrophic cardiomyopathy in general and in the rhasopathies, scarring with fibrous tissue is part of the disease as time passes on. Um, it is interesting. Before Novartis had trametinib, they had a different MEK inhibitor that they were trying to develop, and they proposed a clinical trial, and they were trying adults. And I had some misgivings about that because I thought they might get the heart muscle cells to go back to a normal size, but I couldn't believe that the scarring would just vaporize and go away. So I do think personally that intervening before there's a lot of scarring is the better way to go. So yes, if we had had trametinib for a child with significant HCM when they were a baby or a young child, and they put on it, and the HCM didn't develop or basically went away, I would be hopeful that there wouldn't be scarring down the line. But that's a guess. I guess we'll have to see. I suppose it's possible you could get scarring even without the heart muscle cells getting too big, but I rather doubt that would be the case. I think that they go together. So I would be optimistic that we'll improve that as well. Okay. Any other, yeah, and if people just want to put up a hand, you don't have to type it. If people have any other questions, is there anything else I could answer for y'all tonight? Tuesday, back to you.
Back to me. This is wonderful. Thank you so much for taking this time this evening. I know a lot of people were excited about your willingness to record this session as well. We get a lot of questions about MEK inhibitors, and so obviously we know you're the expert. So thank you for taking this time. We know your time is really valuable. If there's no other questions, then we are done for the evening. We really appreciate everyone signing on tonight. We love seeing the faces of our families. So thank you so much.
Tuesday, can I get you to stay for 1 minute? I want to
I
just try.
can stay for
Yeah,
one
yeah.
minute.
Thanks.
Bye, everyone.
Aha, it's just us. You can
Uh,
stop recording.
wait. Oh, yeah. I need to.
Kill the solutions recorder.
Oh, stop.